Is there anything we didn't cover that we'd like to cover? One of the questions I had, I just ran out of time, is payment. If we have a supply and demand gap, there have been policies that have been instituted in the past to actually pay for, I know there's payment plans for plasma, but to pay for red blood cell counts, things like that.
There's not, it's all volunteer. Right. So we have to work when we do provide a donor thank you to make sure it's very nominal, because we don't want it to be perceived that we're paying somebody for their donation, because that's going to then change the fact that these are all volunteer donors. They're asked a series of questions. We don't want them to be untruthful, because instead they want something.
Is that one of the pitfalls of payment, is that then you've got an incentive there to not be truthful about
exactly.
your history? Right.
I mean, of course, all of our blood is tested, but you're really asking donors these series of questions in an effort to minimize any risk.
Yep.
That's why when you are truthful and upfront and you do really good health screening, the level of blood that does come up as not suitable is less than 1%.
Yeah, it's negligible.
It's less than 1%.
Less than 1%.
Wow.
I don't know the exact number, but I know that it's less than 1%.
Yeah. Yeah.
And that's powerful.
Jeff, what kind of testing is a hospital doing then? And if are you relying completely on the testing they're doing?
We rely on what they provide us. So if they give us the unit, it's a clean unit, and we're gonna use that. We will do some patient level testing to try to match the best unit to the patient. So while you talk about missing types in A, B, and O, unfortunately, there's other things that are in blood, certain kinds of antibodies and other antigens, that some patients need very specific types of blood that are even harder to find, and that adds to the complexity of what we do. And we didn't even talk about the other things that come in blood, like platelets and plasma, factors that we also need to take care of patients. And while I love the fact that blood lasts for 42 days, platelets last for 4. And so we really have to have that ongoing supply in those areas as well, just to do it. I mean, donating blood is the cornerstone of a healthy community. If we don't have a community that continues to donate and provide for the hospitals, it's a complete pay it forward model. We pay it forward, it's available for the hospitals, so when you get sick, we have it for you. And I don't want to have to delay anything.
And platelets are the same, can't freeze platelets?
Platelets can't freeze, no. I wish I could freeze stuff. There's some funky things you can do to make other stuff last, but the big important ones, it's all fresh use.
So Eric, 4-day shelf life for platelets. How many donors do you have donating platelets? And then what is the demand for platelets?
So we pattern our platelet donors really based on what we see from hospital usage over and over. We're pretty good at this. We know what usage patterns are, but again, we're a national organization. American Red Cross is a national organization. There's times that we're completely off. And it's, I need 12 more, I don't have that. And so you're bringing that in from somewhere else. Again, with such a short time span, that's ridiculous to have to move things around any part of the country. So I'm a platelet donor. So it's a longer process, but I sit down and I do 2 units of platelets in about an hour and a half, and they get back to the laboratory, and about a day and a half later, they're off to a hospital. Those are my worries when we get to a holiday as well, because I have Father's Day coming up, and I don't have enough donors on Father's Day. I'm already looking at, do I just change my plans with my daughter and instead plan to be in a bed for that?
And how often are you donating platelets then?
So platelets I can donate far more often than red cells. So red cells I'm looking about every 56 days. As a platelet donor, I can donate, really it's about weekly, but I donate about every 2 weeks.
And what is the process there? Are they drawing all your blood out and then reintroducing blood back in?
So you're using an automated machine, so I'm taking out my blood and then it's going into the machine itself, which is an enclosed system, so it's not mixing with anybody else's stuff. It's centrifuged, it takes out the platelets, it returns my red cells. So what it really does is it's just a single dose of platelets that will be ready in the back, all ready to go to hospitals.
I want to talk about transport of blood also. Red Cross is a regional organization. We have a local chapter. Vitalant is a national organization now. How is transport state to state working? What kind of regulations does our state have that maybe other states don't that would limit what transport of blood is over state lines? Alan?
Well, we are fortunate. Both of us are national organizations. Red Cross is 40% of the U.S. blood supply, and we're collecting in many, many, many markets. But having that scope and span allows us to immediately transport to where they're needed. If there is a disaster zone, say a hurricane or tornadoes, like in the Midwest, we know that they're not collecting blood in those markets at that time, and those patients are still coming in for routine and emergency situations as well as trauma. But now you've displaced all the donors that are giving in that market. Being a national footprint, we are able to move those units into those areas nearly immediately. When 1 October happened, we used the 650 units we had in town and dispersed those to all area hospitals, and then brought in another 450 units basically overnight to supplement what the hospitals were needing on demand just for that. That's aside from our routine deliveries of those. So having that footprint enables us to distribute when it's needed.
And how about Vitalant? Is it the same? Any restrictions on transport?
No, no restrictions, and it's much the same. We saw fires in California, and that's affecting and closing down blood centers and affecting and closing down entire towns. So you're displacing people, but now I have people who've been burned. I need to get plasma there. I need to get platelets there, red cells. We work together to determine where's the best place for us to move that from. And again, we could just talk a normal Tuesday. I have a higher need of 12 platelets here. I've got to figure out where those are coming from. So consistently, it's constant conversations with contacts at hospitals to determine what do they need. So again, they're not sitting there just with empty shelves waiting to call us. They have a supply there on hand, and they know generally what they expect to be seeing that day. But then there will be something, and it's not going to be something huge. It may not be October 1st, but it's going to be a trauma situation that's going to be 4 people show up and there's going to be a higher need. They're immediately contacting us. We're taking care of that. But if there is a shortage of something or there's a rare unit needed, both of us work together to make sure if there's anything needed for a patient who has a rare need, we are actually looking out where can we find that? And it may not be with Vitalant, it may not be with Red Cross. We're reaching out to other blood banks in an effort to find that rare unit.
We have a very large reference library of types that are incredibly rare that we can reference and find people that will meet those very rigorous requirements for certain patients.
And what kind of platform are you using for that? Is there a blood database where you can pull?
There is a blood database, and there's a laboratory that we have that we send our blood to. It's typed, it's cataloged, and kept for those emergency situations.
And Jeff, back to the technology question again, hospital to hospital, how are we communicating on what needs are?
Yeah, I mean, so from us, we're talking to the blood bank directly about, okay, this is what we see coming, this is our surgery schedule, this is what we see changing or we see looking like, or we may have a new patient or other kinds of patients in the hospital that may increase blood needs. So while I talked about technologies that reduce our demand, there are new technologies like the artificial lung and heart pumps that increase our demand. They'll save your life, but they make us use a lot more blood. We have to be reaching out to our blood bank as soon as we identify a patient that we think may go on the technology to say, hey, listen, we're going to have a bump in demand. This is what's going to happen. It's going to be more platelets. And so we'll do that. The systems across will speak with each other. So for Sunrise, Southern Hills, and Mountain View hospitals are kind of part of our healthcare system. We'll talk to them about what we can do internally. Valley does the same thing. St. Rose's do that. And we all talk to each other, especially on traumatic nights through the trauma network about, okay, this is where we are, who's seeing what, where is it, what do we need to move? I just had a bus accident. Can you help us out here?
Right.
And we're a distribution point as well in Las Vegas for blood. So we're on call 24 hours a day, 7 days a week. We have a team there waiting to hear from hospitals that need specific units of blood in specific quantities dispatched on the spot.